Well, good afternoon, everyone, and welcome to today's webinar. My name is Jennifer Erf. I'm with the Massachusetts Association for Mental Health. And on behalf of MAMH, the Massachusetts Department of Mental Health, and the Massachusetts Aging and Mental Health Coalition, I'm very pleased to welcome you today to our conversation called Caregiving Conversations, Reflecting on Race, Older Adults, and Implications for Behavioral Health. COVID-19 has exposed very clearly the disparities that exist and have always existed across our economic and social systems with respect to Black, African American, and other people of color in the United States. For older adults who have or are at risk of having behavioral health conditions, the experience of racism throughout their lives now is magnified and exacerbated by ageism and stigma. So we convene today's panel to consider this question. What would it look like if we really acknowledged and addressed the impact of racism and disparities in providing services to older adults? We hope to look at three facets of this question. First, what is the impact of race and racism on older adults? Two, what are the system and provider level policies and practices that perpetuate racism and disparities, and what can we do about it? And third, what strategies can we use to more effectively engage and support older adults of color? Our panelists today are not only good thinkers about these issues, which they are, but they're also good doers about these issues. They're involved in teaching, consulting with agencies and funders, and providing services directly to older adults. So we're really excited for today's conversation. Nearly 100 people were registered for today's webinar conversation. So in order to accommodate everyone and minimize technical problems, which we hope we're done with now, you're all in listen-only mode. So if you'd like to share a comment or a question, please just type it into the Q&A box at the bottom of the screen. Your question is anonymous. Nobody will know who offered it, and it will be seen only by our team, the five of us here. We'll see that, and we'll try to get to as many questions as we can. And finally, the webinar today is recorded, and we'll send a link to the recording and any follow-up materials next week. So it is now my pleasure to introduce our moderator for the day, Rob Walker. Many of you know Rob. He's with the Massachusetts Department of Mental Health's Office of Recovery and Empowerment, and he'll introduce our presenters and lead us through the discussion. So Rob?
Thank you, Jennifer. And I think it's an irony that just before we began this broadcast, our Commissioner Jo McCullough announced her retirement. That I think it shows that because of COVID, it's really having all of us rethink our lives, rethink our priorities, and think about what's important to us now. And I wish her luck on her retirement. And she was a big catalyst within our own DMH agency about race, equity, and inclusion, and figuring out how we could serve everybody better, including people of color and Latinx and all the other diverse populations we have in Massachusetts. So good luck to her. But this is going to be a great 1-hour webinar, and you don't want to hear me talk. I really want to save time to hear from the presenters. So I'll briefly introduce them, and then I'll let them introduce themselves. But we have Sandra Bailly from Simmons University School of Social Work, Lynda Phillips, who's a private consultant and a social worker by education, and Emmanuelle Renelique from Amazing Adult Day Health. She's the founder and the owner of the program, and all three of our participants have great stories to tell. So we'll start off with Sandra, since she's on my left in my Brady Bunch checkerboard on my screen. So Sandra, you're on mute, Sandra.
Well, thank you, Rob, for having me here today. It's a pleasure to be a part of this panel. And it's a topic of interest, of course, as we've been in the planning mode for this, because I come from caregiving, I guess, before I knew why I was going to why and how I would be using the beginnings of caregiving. So from a professional perspective and in caregiving from, I'd say, the 80s in the Longwood area, from direct service, in a direct service kind of mode, from clinical labs to eventually becoming a clinically trained social worker. Back in the day before all of the Longwood hospitals merged, we were there. And so, caregiving is definitely at the core, and then didn't realize it was preparing me for personal caregiving as a daughter, and providing in-home care to both my mother at one period of time and then my father. So I've watched, personally, and have had the experience personally of what it means to caregive older adults of diverse backgrounds, and what the impact of race does to their care needs as they go along the continuum. So I guess I can pause there and let others introduce, and then I guess, or do you want more at this point?
No, I think more will come out as we speak. Thank you. That was great. And we'll go to Lynda.
Thank you. Good afternoon, everyone. Thank you for this opportunity to share my perspective and experience with having to give care to an elder with complex medical issues. So I just want to give you a little bit of flavor of who my mom is. She came to this country in her mid-20s. She speaks, reads, and writes English. We lived in a multi-generational household up until the late 90s. We've been struggling, and I say we because it takes a village, basically, with my mom's decline because of her dementia. For a long time, we didn't know this is the process or what we were encountering. And we utilized the emergency room a lot because there has been changes in terms of the practitioners that was taking care of her. So this subject is close and near to my heart because I'm actually in it right now. So I'd like to share some of my perspective and also what I've encountered, and I could help someone else. It's probably going to resonate with some of the audience members, but it is a challenge, especially when you're trying to get care and there isn't a comprehensive place to go, and you're encountering some resistance or lack of empathy in the emergency room department. What I realized is the delivery of care, it's inconsistent, and it kind of depends on who you come in contact with. So I'm looking forward to have the discussion. Hopefully this is not the end of it, and just to highlight some of the areas that other caregivers are struggling with, and also what the practitioners in the community can do to help families like myself. So thank you.
Thanks, Lynda. I think you offer a great perspective to the conversation. And we'll go to Emmanuelle, and then we'll have our first poll. So Emmanuelle.
Good afternoon, everyone. My name is Emmanuelle, as Rob put it. I just want to thank Rob and Sandra for inviting me, and Jennifer for inviting me onto the panel. I'm really excited. I think it's a very critical and timely season to have this discussion, so I'm really excited about it. As Rob graciously mentioned, I own an adult day health center, which is a center where seniors and older adults with disabilities come in and spend the day and receive nursing and social care. We have two facilities, one in Canton and one in West Roxbury. My background as a Haitian American has really been seeing how cultural sensitivity plays such an important role as you give nursing care and social care to older adults, even people with disabilities, and how that can assist in their care and assist in their care planning. So I'm really excited to have this conversation and be on this panel. And I know more will come out as the start.
I've never worked with you three being so silent. This is funny. I think it's very interesting that we all have our personal perspectives, our professional perspectives, and the three of you are some of the lucky people that also get to have the experience of being a caregiver of an older adult. And to me, that's just such an honor and an honorable situation to take care of older parents and to have older parents around to be there with us. So I think the perspectives all three of you offer are going to be great. So we want to do a poll, a quick Zoom poll to see sort of who's in the audience, who are we talking to, so we can make sure that our answers are meeting your needs. So if Jennifer's ready, you can post the poll. So it asks, so I know we have a couple of people on the telephone, but what roles do you play in supporting older adults of color who may have mental health needs? Please check as many as apply. So a clinical direct service provider, non-clinical direct service provider, an administrative staff role, a non-paid caregiver, or are you an older adult of color? So please vote now. So I'll get our, so we'll give another minute for you to answer the poll, and we'll go to our first question for the panelists in general. So we often talk about the ACEs study, about the adverse childhood experiences. And the ACEs study focuses on individual level traumatic experiences, like specific to the person and what goes on to the person and their family. But what we're learning more is how some people call the para-ACEs, which is the individual traumatic experiences that we have and we experience, and the traumatic environments. I wonder if the panelists can talk a little bit about the traumatic impact of racism and how that affects the older adults we work with on a day-to-day basis. So, yeah, no, this is great. So, so I wonder if we could get the result from the poll while you all are thinking about the answer, Jennifer. So we have about, and I have eyes over 60, so I have to look close. So the direct service provider clinical is 36% of the people. 54% of y'all are non-clinical direct service providers. 22% are administrative staff. 12% are non-paid caregivers, and 2% are older adults of color.
Mm-hmm.
So thank you. So
well, I'll
we'll
just
start
jump
with Sandra. Yeah.
Sure, I'll just jump in for now and say that you know, I think that COVID has really brought out and amplified really the nature of what it is to be an older adult and facing medical or mental health, you know, behavioral health issues. We're seeing it every day in the media, and I think what that does as a person of color and a person, that meets this older adult criteria is it just adds another layer when you're seeing the constant news media, the constant unrest that has really kind of risen up out of this this time and moment. And so it's just another layer of stressor. I think that it adds to being an older adult. In my beginning, I didn't mention, I too come from a West Indian, hailed family as well. And so, and neither of them are living now, but I could see how in your, at the time, 68 and one passed at 90, it's just another layer. And I think in some ways, thank goodness they're not here to see this time in this society, right? They came to this country really with the idea of the better life and the idea of, having a better future for their kids, right? So one hailed from Panama, one hailed from Barbados, same West Indian kind of origins. And I think it would really just be another awful layer for them to think that their adult whomever's offspring are facing the additional layer of and expose really overt, subtle and overt levels of racism that exist that are coming out in the way that they have since COVID. And so I think that's the trauma of maybe immigrating, naturalizing into a country where you didn't have that experience, the context of racism in the same way. So, but you come into the system, you learn how to navigate, and everybody learns at a different time, but it definitely takes its toll interacting with systems and services, especially when it becomes healthcare needs over long periods of time. I think Lynda had something else, a thought on.
Yeah, I was gonna focus on the emergency room department because not everyone has a primary care physician. And especially if you're a person of West Indian descent, you don't have those easy relationships. You don't know where to go. So the first thing you do if you have an emergency or something minute, you go to the emergency room. And I've had to utilize the emergency room a lot because my mother's primary care retired. She moved to Southeast, where to be closer to me. So we had to kind of pull things together. And while I was trying to find a new care team, I had to utilize the emergency room. So in the town that she lives in, there are 2 hospitals. You quickly learn which ones not to go to based on how you're treated, the long waits, the nurses don't have time to get, a full history. And the emergency room doctor, pops in once and then that's that. And as soon as they hear either depression or hypertension, they kind of write you off, and you're lucky if you get lab work. So which hospital to go to. So every time my mother had a crisis, I knew I was going to go to Hospital B, because at least if I go to the same place over time, they'll get a fuller picture of who this person is. And then I may have a chance on getting a good nurse that is not overworked and will take the time to sit down and ask the critical questions to get to know who's in front of them. And I made sure that I was always there because my mother is now demented and she's already scared, doesn't know the people, so I have to be her voice. So that's how I think with COVID, it's magnified because they're overworked, they're afraid, they don't have time to explain things. And the other thing that COVID kind of exposed is the nursing home system. The most vulnerable of the vulnerable, in how they were not equipped, did not have a national plan. This past March, I had to make the most difficult decision, is to put my mom in a skilled nursing facility because we were no longer able to keep her in the home. it was getting more challenging. I could not find the wraparound services that would help to keep her with us in the community, because every time we got a good plan in place, 6 months down the line, Medicare would stop paying for one service, and then we'd have to start all over again. So I had to go and interview every single skilled nursing facility that was close to me because I want to be involved. And it's a little scary when you're watching the news and then you hear of all these elder folks that are passing away. The staff do not have a plan. There's cross-contamination. You have these huge conglomerates that own a whole bunch of nursing homes and they're sharing staff. So that's kind of scary. And folks that are in assisted living, which if you have the income you can afford, you kind of have a better chance. So all these things have gotten magnified, and I'm really hoping that maybe legislation will come out of this or there'll be a grand plan, but I'm not so sure. So that's how I see it playing out day to day. It's based on the region that you live in where you kind of get the resources and the help.
Thanks. I want to give Emmanuelle a chance to answer this, and then we can go on.
Yeah, so I'm going to give a perspective both from the provider perspective, but also as an advocate. When I think of the role that race plays on healthcare, especially for older adults, one of the key aspects that comes up, especially in Massachusetts, is language, right? So a lot of the, some older adults have a language barrier. So some of it is they don't speak the language, but a lot of it is even for the English speakers, they may not understand like the terminology. For example, what does, healthy eating really mean? That's simple because the term is healthy eating, or their diagnosis. Some of them don't always understand their diagnosis. When they go to their doctors, do they understand what the doctor is actually saying and the implications of their health? When I think of some of my members who are predominantly, not all, but predominantly non-English speaking, they're Haitian, when they go to the doctor and they are speaking to a provider, their primary care and or any other specialist that they attend, do they understand what the doctor is asking them to speak, asking them to do outside of a interpreter? For example, if the doctor says, lay off on the rice that we know that they love, or, you're maybe, certain conditions are necessitate you to change the way you eat or exercise more. Do they understand that when they're asked to take some of their medication? Do they understand exactly what the dosage is? Is there a provider in place to help them with that? Also, when I think of care coordination, so from the doctor's office to when the senior or client gets home, is there the care coordination to assist with helping with their overall health? Like if they have certain prescriptions to take for their various conditions, do they understand what to do? That's where we come in, especially as the adult day health. We have those interpreters that are going in. But when we think of seniors, for example, a Haitian senior that goes into their doctor's office and they have a hypertensive diagnosis, how do they know how to deal with that outside of an interpreter? If they don't go to the hospital with their daughter or son, do they understand what the doctor is speaking to? Are they just smiling and saying yes?
Yes.
That's the only term that they know, or good. When the doctor says, how are you doing? They're saying good. They're not actually explaining, no, I'm actually not doing good. I have pain, or I have persistent pain, or I have different things. So that's where I find the disparity for non-English speakers and or race, and that's how it implicates some of our older adults. And I could give more examples, but I didn't want to.
Right, and I guess I will weigh in. I'm kind of the panelist that I have like a 7-year period where I haven't been the caregiver, and but with my dad being the last person to take care of who ended up having dementia, but prior to his decline, he he would have gone, he's English speaking, very English speaking, and he would have gone to a hospital or his provider, and it would be more of a social call. It was not, he didn't see it in his orientation was not in the sense of it being a medical call for real. He might have pain and he'll talk about that, but he would turn it into a social a visit, more so to speak. So even if they told him you need, you have glaucoma, you need to take your eye drops, you need to do this, you need to do that, it would go in, but it would be, okay, it would be a head nod, but it wouldn't necessarily, if I wasn't there, it wouldn't necessarily be something that would have follow through. Home care, the idea of someone coming into the home, that wasn't something that, he was that receptive to. If they came for other things and it would be a social visit, that's a different thing. And so I think that's another factor, and it's really around the cultural competence of the providers and truly building relationship to get to the nuances of who this person is, who the patient really is in front of them, and what are the things that may motivate them to be more consistent in doing whatever is needed for their care. I guess I'll say it that way. Yeah.
Oh, thank you. That brings me to that's a perfect segue to the next question, which is really sort of, what is it that you want providers to know? We have a lot of direct care clinical providers on this call. What is it that you would like them to know about providing services to BIPOC, to people of color, older adults?
So, where I am representing also as an educator at one of our universities with one of the schools of social work, and a part of the curriculum, a part of them getting students out in the field is really that understanding of what is it to build relationship, what is it to come at it from a perspective. You're assessing your client, your patient, from the perspective of relationship, as well as really truly understanding the cultural context that they come from to inform the assessment that you're doing. And I know that others here will have be able to add to that, but I think that that's one aspect that we are trying to get the kind of providers, service deliverers out in the world from the discipline that I'm talking about, that are oriented with the knowledge and truly understand then how to apply it. You're also trying to get as many people that may look like the actual older adults that they're going in the community to serve in the places that they need to be, and to build that kind of pipeline that allows for that, because it makes a difference in how care is understood and delivered. And so I think just kind of, and that's we could speak more to that as well, as how we try to do that, and how many of us have met within that type of interaction, is really trying to look at what exists today, who's out there, who's delivering the service, and how do you build their capacity in the buy-up arena.
Representation matters.
Yeah.
Yeah. So I know Lynda has things to say.
So, I mean, for us, I'm still right dap in the middle of it. As a provider, I just need you to listen, to just kind of ask what was going on before, what worked well. I mean, I'm realistic that my mother is late stage dementia. Right now, my focus is quality of care and making sure she has dignity. I know miracles are out. I get that. Just to kind of treat us like we were a family member. Just ask us, how can I help you? And then just doing a little bit of research, finding out what our goals are, what we want to do, and not to assume anything, and just ask questions. We're okay with you asking questions. That would go a long way. and not handing, someone a 7-page piece of paper and say, well, what do you want me to do? And actually, a physician actually said that to me, because my mother had stopped eating. She lost over 100 pounds in 1 year. We didn't know what was going on. My aunt's a nurse. My mother used to be a nurse, and we're doing research when we're talking to the physician stating, she's losing a lot of weight. Don't tell us there's nothing you can do. If we're asking for blood work, we're asking for, we don't want to do anything invasive. I get that. But we did a little research and we found out after a while, a demented person doesn't know that they're hungry. They could say when you offer them a meal, no, I'm not hungry. You go back 30 minutes, you ask them again, and then they're hungry. Little things like that. When the physician, when we brought her to the emergency room, said, look, we're really concerned. Something's not right. She's lethargic. And come to find out, I'm really glad I brought her to the emergency room, because she was dehydrated and her sodium level was through the roof. Who knew? If she had stayed home any longer, she could have passed. Right. Then in talking to a really nice nurse, I got lucky that evening and explained what was going on. They did the blood work, and then, she was explaining that, well, I think it's the weight loss is probably due to the dementia. And I figured, well, what are our options? I should be telling a trained physician, well, what about a G-tube? Since we're afraid she might aspirate. So just kind of doing your little homework and providing us with our options and not leaving the family member to their own devices. That would be helpful.
Thank you. Before we go to Emmanuelle, I just want to encourage people to post your questions you have for the panelists in the Q&A balloon that's in the bottom middle of your screen. So thank you, because we want to try to make this interactive as much as we can. So Emmanuelle.
So one of the key things I would say to providers that are on the call are try to approach most of your, if not all of your encounters with a cultural sensitivity. So that one of the key reasons that we opened the centers is we wanted to create a space where seniors felt that they were getting the social and the nursing care, but with that cultural sensitivity. So you might not always have like a cultural context or a cultural background that allows you to have that context, but if you approach it with that openness, that, okay, if a senior is just smiling and saying yes, saying, oh, wow, are they agreeing, or have they been socialized, or is yes the only word that they know? Having that context. An example I always give some of my staff here is, or a social worker, if you call a client's house and they're not answering, don't assume that they don't want services. It might be that they screen, or some for, now, because we're not doing any more, most people aren't doing any more in-person services. But if you ask to go into a client's home, for example, and they're reluctant, it's not because they're hiding something, it's because culturally, some people are naturally more private, or they're not comfortable with providers going in initially. They need to build a rapport with you before they can allow you to come in to do that initial home visit. It's not because they don't want the services. It's not because they're not interested. They simply have been conditioned to not accept people to come into their homes so openly. So you have to build that rapport, and being open to that, being open to building that rapport, don't be discouraged after the first no. Or if a client says like, no, say, wait, all right, so try to be more understanding. Try to understand where a family may be coming from. If you speak to like a daughter or a son or someone and they seem like tired or frustrated, coming from that, adding that extra level of, okay, why are they frustrated? Because they're not interested in their parents' care, or are they frustrated given what they have going on, and allowing that context to drive how you communicate with them.
No, thank you. And that brings up another point. I don't know if you all want to comment on this, but there was a big report from the Blue Cross Blue Shield of America company about caregiver stress, especially in the time of COVID, and what Emmanuelle was talking about, the depression and the anxiety, and sometimes the suicide rates are going very high with caregivers in this time of COVID and before COVID, and how that affects their health. So what kind of support, this isn't one of the questions we talked about, but what kind of support can we give caregivers of color that are doing the caregiving role while their kids are home taking school, while they're working from home online,
Yeah,
and everything else?
Rob, I'll jump right in.
Yeah.
During the pandemic, we had to close our physical doors and pivot to remote services. And that was actually one of our offerings. We started a weekly programming for caregivers. We called it Weekly Wednesdays Family Forum. And it was a call line where families and caregivers could call in every Wednesday for an hour, and just and they had access to our nurses and social workers, and they can just vent, talk about what was going on, because some of them, it was their first time being in home with their moms or dads or sisters or brothers for such a long time. They also were getting tips like what to do with their parents during the day. Do they take walks? How do they administer the meds for the ones that are assisting with med management? How do they now prepare meals? Because a lot of our clients receive meals during the day here at the center, but now the caregivers have to prepare healthy meals or meals that are appropriate for their different diets while in the home. And we provided that forum and that safe space where they can call in and get some of these tips. So for the caregivers that are on the call, for the caregivers and or providers that are on the call, give a space for the caregivers and your families. Like, your client is obviously your client or your patient, but leave room for the caregiver to also build a rapport with you where they feel comfortable, because the client will feel more comfortable with you if they feel like their daughter or son has a good rapport with you. I find that the clients are a lot more receptive if they feel like their daughter or son trusts you. Then they're like, okay, great. My daughter, my son trust you, and that kind of opens a door more for them to trust you as their provider, whether you're a social worker or home care.
Yeah, that really is true. I was sitting, I paused a bit because I'm thinking, well, how do the providers know? So I think that to Emmanuelle's point, it's really thinking about, what actions can you take when you look at your actual services that you're providing, right? What can you do that's different, innovative, that would help to expand and think about, that caregiver in the house, since you know the patient or the client directly. Making use of the virtual world that we're now in, older adults and non-older adults, but older adults are feeling isolated, right? And so, the isolation is real, and to the extent that you can create those types of check-ins and extend to the givers as well, I think is a really important offering that I really wish those things existed in the time that I was doing the caregiving. So it's would have loved to have had adult family homes that were tailored to understand the cultural backgrounds that each of my parents came from at the time that they needed those services. So I think it's thinking in those ways. I think that's the ask to providers that are out here today, is to be thinking about who is in your practice in a holistic way, and different ways that you can angle some of the delivery to extend it to the caregivers as well. That's smart.
Thanks. So we had a question from the audience. So what are some best practices to improve access to services, to older adult services, for those with limited English capacity? How do you reach and provide access to people who are limited English speakers? that might,
That's in the manual.
I would say
It's-
a best practice is staying open to the resources that are available. There are multiple resources available on the state's website, on the, I know most providers actually provide translation, and their brochures are in multiple languages. The information is definitely out there. So I encourage people to, look for it. But I always encourage people to, if you, for example, you encounter a client that's looking for a doctor that speaks their language or a provider that speaks their language, and they don't, and you may not have access to that doctor or that speaks the language, but there are always interpreters. A lot of the doctor's offices have interpreters of all languages. Like, you'd be surprised. Or in terms of resources that are out there, there's a lot of resources. I think we have a resource guide. I think Jennifer.
I think I'll also add as well, because many of my years were spent on the payer side as well, is that, don't forget to tap the folks that are your payers. They have a suite of medical management type people as well. And they also have, through their provider services, language material and collateral in all languages is available as well. So don't forget about the payer as well as a source of getting some of the resources that you may need for non-English speaking patients.
Actually, I was thinking about some offices have access to a language line, because not everyone may be comfortable with an interpreter. Because what I've learned is sometimes it could be someone that's from your community that's the interpreter, and that might not go well. But just maybe to ask if the particular provider has access to a language line. And nowadays, I have to say the payers are so savvy where they have a multitude of, different, to Sandra's point, language capacity, where, because I know when I had called Old Colony, elder services, and then if you speak this language, press this, Cape Verdean, Creole, press. So people are getting a little more savvier out there.
and I also think what Sandra mentioned in the beginning too is don't hire everybody that looks like me. Hire people that look like the people you're going to serve or the people you want to reach. I mean, improve your hiring. And Sandra's working on the Sandra's working on the other end, hopefully, to get the supply of multilingual social workers educated and hire them. So to expand your hiring practice and to expand where you're recruiting potential employees from. So we had another question, and I'm wondering about this too, Emmanuelle, because I'm looking at my golden years. People wanted to know how can people register or sign up with your program? We had two people asking that. So do you want to give your website? Is that the best place to start?
Our website, or they can get in touch with either center. We have a really great referral program. So if you call in, our intake people will help you guide through the process, I should say. So you can call 617-930-4637 or either center 781-562-0444. We'll put the phone number in the chat in order to get in contact with us.
Awesome.
We're also available on most of the social media sites as Amazing Adult Day Health.
Awesome. So there's a question that we actually struggle with at DMH when we're working with parents of young adults receiving service and that's about how do you all handle the HIPAA restrictions about communicating with family members? We have parents of 20-year-olds that have that have those exact same issues, I assume, as sons and daughters of older adults.
Mhm.
So I was wondering how do you as provider, or Sandra as training social workers, how do you handle that? How to be proactive with the HIPAA restrictions and rules?
Yeah, well, I'll just speak from the social work and then the daughter hat, right? Is that
Yeah.
hopefully you are, for those older adults that have adult family of some sort that's that they're engaged with, that they're using as their as their caregiver, that they are usually very open and wanting to have that person there to help them navigate the system. So they are allowing you that access as far as communications with their providers. And so from an adult child caregiving kind of to a parent, et cetera, that type of, or an older adult. And so the HIPAA piece, wasn't so much of a hurdle for me to it wasn't a barrier at all in my interactions, because both parents were very open. But then when we talk about cultural context, et cetera, that initial, when a diagnosis comes, that initial, if it's not within their comfort level norm, in their context to not just accept the diagnosis, but just to share it. Within certain groups, it's just not one of those things you talk about certain diagnoses. So cancer isn't something that would be something that there wasn't the comfort level to talk about. And so you may not know, or in my case, I didn't know early enough when cancer metastasized in my mom's case. And so, but a provider who happened to have been from the roots of one of our 3 or 4 nations here knew to call, and at the time I lived in the Northwest, knew to call and understood immediately, again, that rapport and that likeness, right? So knew that this was a proud mom who didn't want to burden her, the cultural context is burdening her adult children with this type of need. And that physician, it was a Jamaican, I think, resident, who just jumped on the phone and had this conversation with me. And
Wow.
that's how I knew, immediately we need to get into action now. And the conversations around, it was end of life at that point, but palliative care hadn't started. And so how do you, it just goes back to everything we've kind of talked about, is having relationship, or having enough people or as providers on the scene that understand the nuances of what someone's expression or hesitation or facial or whatever that is may be, that allows them to build the rapport so that they can get ready. So HIPAA, it didn't get in the way, or it was never a barrier in either of my multiple years of doing the direct service. So I don't know.
How about Lynda? Because I know you're probably dealing with it on a daily basis.
Yeah. So when we kind of figured out what was going on with my mom was beyond, the depression and hypertension, I think I started to have conversations with her sister and brother. And because I come from a social work background and had worked at the Brigham, I saw the dynamics of family members that didn't want to share information. They didn't talk to this sister or this brother, and the mother was torn. So I said, I think we're in for the long haul. We need to start talking about healthcare proxy. I'm going to start going to the appointments because I need to know what's going on. At this point, I'm around elders, and they can't take on the burden to help their sister, or daughter. So it was me, I had to step up. So we just had a conversation. I said, let me go and introduce myself to the providers, get her to sign all the paperwork, because I knew eventually things were not going to be good. And then we did the healthcare proxy. I explained to my mom what it is, and this is a lot. I need to be able to kind of help you make some decisions, And it came in perfectly because when we started this conversation, it was 2012. So here we are. She has good days, bad days. She can't make the medical decisions for herself. So that's helped me to sign all the right papers and to do things on her behalf. The only thing that I did not feel comfortable doing, and it might be a cultural thing, is I did not want to take guardianship. I did not want to go down that route. For right now, I think the healthcare proxy is all that I need. But I got lucky because there's some other elders that do not want to give that level of control up. And I think just having the conversation early. The other
Yeah,
thing,
you're being proactive. It's being proactive about it.
You have to be. And also another tough conversation that I would encourage the providers to have is advanced directives. It was a tough one. It took a long time. When the subject came up, I had to sit and talk to her two surviving siblings, which is a sister and a brother. The brother was not on board, but I said, listen, we don't want to do extreme measures, especially she's frail. And there was some tough conversations.
Wow.
And I just want to piggyback that exactly what you said, Lynda, asking upfront. So having the cultural context of this is knowing that in some cultures, the older child makes all the decisions.
Yep.
And the child that's the person that's bringing the parent to the doctor may not always be the decision maker. They just might be tasked with assisting their parent to the doctor's office. So just having that, and they also can't be the decision maker because of whatever cultural, nuances are going on. So just as a provider, just asking in the initial visit, hey, who's going to be the one making majority of the decisions? And asking your client or patient, hey, are you okay with so-and-so, and designating a decision maker just so that you're clear, everything is up front. That way, you know that you're only communicating with one person, because it could get a little dicey if you're communicating with multiple people and then certain people aren't supposed to know certain things. And again, just using that cultural sensitivity to know the importance of who's going to be the decision maker for this client going forward. How do you communicate with them? Do they prefer, electronic communication? Do they prefer paper? And having those conversations up front.
And not all family members want to take that on.
No.
Because, there was one family member that was totally overwhelmed, was afraid to make the decisions. But for me, I have a partner, which is her sister, because I want to make sure I'm doing the right thing. And, it is her sister and she has a huge stake into it. So we have a nice partnership. I have a limited medical background. So whenever, there is a care plan meeting, I invite my aunt to make sure, like, okay, this is what they're saying that they want to do. What do you think? And then we discuss it.
So we have 5 minutes, which is great. So another question from the audience is that, so what's the sort of the most damaging aspect of the racism in the healthcare system, do you think? What's the negative effects of healthcare system racism that's most damaging to older adults of color? And sort of what's the best anti-racist healthcare delivery model do you recommend?
Well, I can tell you right now.
I don't know if we'd be on the panel though. Would we? We would have the answer.
Yeah, I know. Be in private practice, yeah.
I think the most damaging thing in my case was the delay in diagnostics. If, let's say, 10 years ago that she had gotten the psychological testing or the neurological testing, I think we would have known what we were dealing with. And then I wouldn't have gone through all this odyssey and just feeling ignored when we know that some of the things that were happening with her was out of her character, and the irritability, and this was beyond depression. it seemed like no one really listened. And they just kind of, because of the age, well, they just assumed and didn't have any science to back it up. I think I lost a good 10 years. So.
Yeah. For myself, I think I was thinking it's the subtle, the subtle dismissiveness, of the subtle, what we hear about is microaggressive types of things that happen. And that can happen in the ER with wait times, an older adult with somebody with them or not with somebody with them, but especially I can think of a time when and this is right in our local Boston major hospital, where my mother, it was before we knew she even had any kind of diabetes. It was the onset of it, and what that experience was to bring her first to her primary care, who she had great relationships with her primary care person, and to go to that office first because I come from healthcare and said, oh, I want to utilize it in the right level. Go take her there first. We noticed a change in her, and it was just not her. And there was maybe a resident or somebody in the office that, it was a dismissive experience. Then I took her to the ER. And if I hadn't known a resident, and this is back when I was in graduate school, and it was we had a team. We had a team of people that I knew in different hospitals in the Longwood area. And if I didn't have a growing up friend who was a resident there at one of the hospitals, in that same hospital, to call to say that's not the Mrs. Best that I know, and come to the ER to see what's going on. I mean, at that point, her sugars, it was like a 600 level, which she was pre-death as well. But it shouldn't take that. It shouldn't take that kind of navigation to be heard and seen. And so I think you want that was the 90s, this 2000s, we can 2020. I don't know how much has changed, but I know that we all have those kinds of examples that we could share. And so I don't know that the pervasive racism from a systemic perspective has really, and biases haven't changed to the extent that we need them to.
If anything, it's gone more underground.
Right.
But I want to turn it over to Jennifer Erf to wrap it up. And the hour went by so fast. I knew we should have scheduled 2 hours for this, but this is such an important topic that all we really got to do was scratch the surface. But go ahead, Jennifer.
Yeah, well, you scratched the surface in some great places and deeply in some places too. So I just really want to express my thanks to Sandra, Lynda, Emmanuelle, and you, Rob, for a really great conversation. Emmanuelle mentioned a resource list, which we do have available, which is just kind of a summary of some of the tips that you heard today, and also some links to some articles and other information, a toolkit that might be useful to you. So as soon as we have the recording for this webinar available, no later than early next week, we'll send a link to the recording as well as the resource list to all of you. So again, thank you to the panelists and to Rob, but a very special thanks to all of you for joining us today. We're really happy you could be here. Thank you and enjoy the rest of the day.